Those of you who don't know me, I am the solid organ transplant PGY2 this year. By the end of this presentation, I'm really hoping that you'll have a good understanding of what autosomal dominant polycystic kidney disease is, and then be able to talk about the conventional and non-conventional treatment options that are available. We're going to start by talking briefly about the background of ADPKD, is how I'll kind of be referring to this going forward, since autosomal dominant polycystic kidney disease is quite a mouthful. We'll then talk about consensus guidelines on how to treat this disorder, and then dive a little bit deeper into those novel ADPKD renal protective treatments. As we progress through this presentation, I want you to think about our patient MK. So he's a 36-year-old male who presented to his primary care doctor for just a routine physical. He had no past medical history, and only significant family history was ADPKD in his mother. He's overall doing well and doesn't have any complaints, not having any symptoms of anything, nothing going on in his life, was just there for his routine checkup. However, he was hypertensive during his visit for 2 separate blood pressure checks with systolic blood pressures in the 150s. So his primary care doctor decided to start him on amlodipine 5 milligrams daily. All right, so some of you might be wondering what ADPKD actually is. I think as pharmacists, we're all familiar with end-stage renal disease as a whole and chronic kidney disease, but oftentimes, being pharmacists and not physicians, we're not very privy to the underlying causes of renal failure. So ADPKD is actually a relatively common genetic disorder that results in the development of fluid-filled cysts on both kidneys for most patients. Sometimes it can just be one kidney. However, this eventually, especially when it's in both kidneys, leads to end-stage renal disease. It's actually a pretty common genetic disorder and affects about 1 in 10,000 people, with about 12.5 million people worldwide across all ethnic groups having been diagnosed with ADPKD. It's also reported that ADPKD is the 4th leading cause of renal failure in the United States and responsible for 10 to 15% of patients who are currently in end-stage renal disease. So to kind of give you an idea of how many patients this affects, this is actually a pretty big burden on public health. Now, the underlying pathophysiology of ADPKD is still largely a mystery. What we do know is that the proteins polycystin-1 and polycystin-2, which in a normal person work together to regulate cell growth, division, movement, and interactions with other cells, are actually key players in this disease pathology or process. Because genetic mutations in the genes that code for these proteins are highly related to pathogenesis of ADPKD. Additionally, there's some evidence that suggests disruption of signaling pathways with intracellular calcium, CAMP, the mammalian target of rapamycin, and vasopressin can accelerate cyst growth and lead to disease progression. These cysts can form on various different parts of the nephron, and when enough of them pop up over time, it leads to renal dysfunction. In terms of symptomology, most patients with ADPKD are largely asymptomatic until their 3rd or 4th decade of life. If you do have patients who start presenting with symptoms at younger ages, this is usually associated with more significant disease or more rapidly progressive disease. Most common presenting symptom of ADPKD is hypertension in an otherwise healthy adult who doesn't have any other underlying cause of hypertension. As the disease progresses, patients will start complaining of flank pain due to the cysts themselves and inflammation along the abdominal wall because of those cysts, as well as hematuria and proteinuria, and then increased incidence of both UTIs and kidney stones. The gold standard for diagnosing ADPKD is actually just imaging, as the renal cyst can be really well defined and well visualized on something as simple as a renal ultrasound. You can also see cysts on both computed tomography or CT scans, as well as magnetic resonance imaging or MRIs. So Typically, for most patients, when there's when ADPKD is suspected, the physician will just order an ultrasound to confirm or rule out based on whether or not cysts are present. And you can see here on the slide, this is I believe this is an MRI of patients who definitely have a much higher cyst burden than you would see in early disease. So this is certainly rapid degrees, but you can see the even size of cysts vary, but it's pretty obvious that you can see them on imaging. Genetic testing is also an option. So I had mentioned before that this is an inherited disorder. And if you remember from whatever class we learned about genealogy in autosomal dominant, meaning that in a child who has a parent who has ADPKD, they have a 50% chance of having the disease themselves. So genetic testing is certainly something that can be done to confirm or also rule out ADPKD. It's not typically done because, as I had said, imaging is in the setting of family history as well as symptomology in the patient is pretty good at diagnosing the disease itself. For the most part, genetic testing, really the only role here is for family planning in patients who do have disease to try to prevent passing that on to their own children, or in the setting of kidney donation in patients who potentially have a sibling with ADPKD and would like to donate a kidney just to confirm that the person donating does not also have the disease. Monitoring patients with ADPKD can be difficult since early on in disease, there actually isn't a lot of renal dysfunction that you can see on laboratory testing, simply because the remaining nephrons that are not taken over by cysts actually do have a lot of hyperfiltration. As you can see here on this pictorial representation of how cysts can grow over time, when the number of cysts become such a high burden that there are not really any working nephrons available, that's when you do start to see a decline in the eGFR or kidney function of the patient. But it can take a really long time for patients to actually start having renal dysfunction in this disease. So something that has been used as a marker of disease progression, kind of a surrogate marker, is total kidney volume, really evaluating how many cysts are on those kidneys and what that cyst burden is to kind of mark where a patient is at in their disease progression and estimate when we're going to start seeing a decline in eGFR. As those cysts continue to grow, one of the issues is that the renal vessels do get compressed, and that results in ischemia and then subsequent activation of the renin-angiotensin-aldosterone system, which then puts more stress on the kidney and produces more cysts, and that is ultimately why patients end up in end-stage renal disease. All right. So now that we've learned a little bit more about ADPKD, we're going to put your knowledge to the test. MK has returned to his PCP's office for a blood pressure check after starting amlodipine, and unfortunately his blood pressure remains elevated and he's complaining of new symptoms like flank pain. Which of the following diagnostic tests should his PCP order to assess for the presence of ADPKD? If you could put in the chat what you think your answer is it A, a renal ultrasound, B, a BMP or basic metabolic panel, C, genetic testing, or D, all of the above? Okay, so I'm seeing a few D's come in through the chat, so thank you everyone for your participation. The correct answer here is actually A. So you certainly could do genetic testing, especially if you knew which gene the patient's mother had that caused ADPKD. A BMP maybe wouldn't be super valuable here in this setting, as this patient probably is in early stage of disease and might not have manifestations of end-stage renal disease and might actually have a normal serum creatinine. And a renal ultrasound is probably the best choice for him because it's relatively low risk, it's non-invasive, and it's pretty easy to perform and has a really high diagnostic efficacy in terms of ADPKD. Okay, so MK is off to his renal ultrasound, while we wait for his results, we are going to talk a little bit about how to treat ADPKD. So surprisingly, even though ADPKD is the fourth leading cause of end-stage renal disease, there aren't actually any clinical practice guidelines to help providers treat this disease. And largely that's because we don't really understand how it works, the pathology behind it, and for that reason, we don't have a lot of great drug treatments. The Kidney Disease Improving Global Outcomes, or KDIGO group, is actually currently working on a clinical practice guideline because there is some evidence out there that we'll go through today that really probably should be in a treatment guideline for our nephrologists to refer to help manage these patients. And in the interim, this group did release a summary from a recent controversies conference on ADPKD to help guide physicians and providers while we wait for this guideline to come into play. So big summaries from this conference were that there's ultimately no cure for ADPKD. Most patients with this disease will end up in end-stage renal disease and require either dialysis with preference for hemodialysis over peritoneal dialysis, just given the anatomical issues with cysts on the kidneys, or more preferably renal transplant for kind of an ultimate replacement of the diseased kidney. There are some recommended renal protective or conventional renal protective treatments that will walk through things that you've heard for other patients with chronic kidney disease that have been shown to work well in this disease population, as well as some novel ADPKD renal protective treatments that is really still uncharted waters, but we're starting to gain more movement there. So starting off with those conventional renal protective treatments, as you probably remember from just general chronic kidney disease, tight blood pressure control can help prevent progression of end-stage renal disease. So for our ADPKD patients, a blood pressure goal of less than 130/80 is typically recommended. There's also been some evidence that in really young, healthy patients who can tolerate it, an even stricter blood pressure goal of less than 110/80 might be beneficial and prevent cyst growth, and actually has been associated with decreased cyst growth. So I've kind of alluded to talking about the pathophysiology of ADPKD, the preferential use of an ACE inhibitor or ARB, as these interfere with the renin-angiotensin-aldosterone system, is preferred. And those medications have been shown in both animal studies and human studies to prevent or delay cyst growth as well. Another consideration for patients with ADPKD is hydration. There have been some studies that suggest patients with ADPKD should aim for actually pretty high hydration goals, upwards of 3 liters per day. And the reason or the thought behind why this has been effective in decreasing cyst growth is that this increased hydration can actually suppress vasopressin release, which I will kind of talk about later. This is a little primer for one of the medications or drug targets, but that theoretically should also decrease cyst growth. And lastly, patients with ADPKD should consider following both renal and heart healthy diets, including sodium restrictions of less than 2 grams a day, low protein diets, and a low phosphorus diet. All right, so back to our patient MK. His renal ultrasound read is back, and unfortunately he has 11 cysts on each kidney, which is consistent with ADPKD given his age and symptomology as well as family history. So his PCP has officially made the diagnosis. Before his PCP sends him off to a nephrologist for better management, he does want to make a couple changes, has some ideas, and is wondering what recommendations he should be making for this patient in terms of management for ADPKD. So again, if you could put in the chat what you think the answer should be, either A, switch his amlodipine to lisinopril, B, maintain hydration of greater than 3 liters per day, C, limit dietary sodium intake, or A or D, all of the above. Perfect. I'm seeing lots of D's go into the chat here. And that is correct. All three of these things would be beneficial for our patient MK and hopefully decrease the cyst growth for our patient. All right, so now we are going to move on to the more AD-PKD renal protective treatments. There are three drug classes that have really been studied in AD-PKD, and this includes mTOR inhibitors, somatostatin analogs, and vasopressin receptor antagonists. We're going to start off with the mTOR inhibitors. So there are three different agents that have been studied in AD-PKD, including rapamycin, everolimus, and sirolimus. And you might be familiar with these drugs in other patient populations, such as solid organ transplant, where they are used for anti-rejection therapy, as well as in hematology and oncology, as these medications can be used to treat a variety of minor cancers. The mTOR inhibitors ultimately interrupt the cell cycle and prevent renal tubular epithelial cell proliferation. And for that reason, they've been shown in animal models to slow cyst expansion and preserve renal function. Unfortunately, in human studies, this has not been as promising and has not shown the same results as what we've seen in our animal models. One meta-analysis by Lin et al. Evaluated 9 randomized controlled trials with about a total of 784 patients who were treated with either everolimus, sirolimus, or rapamycin versus placebo in 6 trials, and ACE or an ARB in 2 trials, or octreotide in 1 trial. And these patients were followed for 6 to 24 months, with primary outcomes being assessed of total kidney volume and decline in eGFR from baseline. Additionally, per the usual, adverse effects were studied as a secondary outcome. Unfortunately, as I alluded to on the last slide, this meta-analysis really reported that there was no significant difference in either total kidney volume or eGFR, demonstrated by this forest plot here. In terms of adverse effects, the mTOR inhibitors were more significantly associated with adverse drug events, including aphthous stomatitis, diarrhea, and cutaneous abnormalities as the most frequently reported adverse effects. So for this reason, combined with low efficacy, poor side effect profile, mTOR inhibitors are ultimately not recommended in the treatment of AD-PKD at this time, but ongoing trials are still going on. Next, we're going to move on to the somatostatin analogs. This includes octreotide and lanreotide. These are anti-secretory agents that have a variety of uses, from things like acromegaly to diarrhea. In pancreatic transplant, we use them in a lot of different settings. For the treatment of AD-PKD, the reason that these agents have been proposed as potential treatment options is that they appear to inhibit cAMP production in renal cells, which is thought to decrease proliferation and fluid secretion into cysts. In animal models, we have seen that somatostatin analogs and just endogenous somatostatin can reduce kidney weight, cyst volume, and renal fibrosis. However, one caveat even in these animal models is that renal function seemed to be largely unchanged, even with all of these other modifications to the kidney vasculature and physiology. So a systematic review by Griffiths et al., systematic review and meta-analysis of 6 RCTs or randomized controlled trials with a total of 592 patients reviewed, evaluated patients who received a long-acting octreotide depot injection of 40 milligrams every 4 weeks versus lanreotide or lanreotide 120 milligrams every 4 weeks compared to placebo. Similar to the mTOR inhibitor studies, patients were evaluated for 6 to 36 months, so a little bit longer of evaluation, and primary outcomes evaluated were total kidney volume and decline in eGFR during the study period. Secondary outcomes included adverse event monitoring, progression to end-stage renal failure, all-cause mortality, and hospital admissions. For the primary endpoints, there again, unfortunately, was no significant reduction in total kidney volume and no significant difference in eGFR decline. It doesn't mean that there wasn't any difference at all. It did appear that the patients who received somatostatin analogs did have more reduction in total kidney volume or less increase in total kidney volume during the study period, just not enough to be statistically significant. And same with eGFR decline. The patients in the somatostatin group did not experience as much of an eGFR decline as patients in placebo, but again, not statistically significant. Adverse effects due to somatostatin analogs were plenty, including hyperglycemia, diarrhea, abdominal pain, cholelithiasis, cholecystitis, and alopecia. So, as you may have guessed, similar to mTOR inhibitors, these medications are not recommended in ADPKD at this time. But there are a lot of studies still going on, as kind of some of those results suggested maybe they are effective, we just don't know how to use them yet. All right, so moving on to kind of the meat of our presentation, we're going to talk about tolvaptan, which is a vasopressin receptor antagonist. It's been proposed for the treatment of ADPKD because it can target fluid secretion from those renal tubular epithelial cells, which theoretically probably contributes to cyst growth. This occurs because the vasopressin actually disrupts cAMP production due to competitive inhibition at the V2 receptors on the renal epithelial cells. And for those of you who are visual learners, this is a pictorial representation of how tolvaptan is proposed to work. So you can see these V2 receptors on the actual renal cell epithelial walls. And this is actually a renal cyst. So normally vasopressin comes in and binds to those V2 receptors and promotes secretion of fluid into the cyst, which can lead to the cyst enlarging and causing more problems. And then we have tolvaptan here, who is actually a competitive antagonist at this V2 receptor. So tolvaptan comes in and prevents vasopressin from binding and therefore decreases secretion of fluid into the renal cyst. So theoretically, this might decrease cell proliferation and fluid secretion to delay disease progression. So the landmark clinical trial for tolvaptan is called the Temple 3-4 trial. This was a phase 3 double-blind, placebo-controlled, randomized controlled trial across 129 sites worldwide that included patients who were 18 to 50 years of age with a diagnosis of ADPKD, a total kidney volume of at least 750 milliliters, and a creatinine clearance of at least 60 milliliters per minute. So these patients had to not be pretty progressed in their end-stage renal disease. So if you remember from our chart, this would be stage 2 CKD. Patients were randomized to receive either tolvaptan titrated as tolerated to a dose of 90 milligrams in the morning and 30 milligrams in the evening versus placebo. Interestingly enough, the study did report that adherence was actually checked with patients via reported pill count and exceeded 90% in patients in the tolvaptan group and 93% in the placebo group. These patients were followed for 36 months with follow-up at baseline, randomization weekly during titration of tolvaptan or the placebo drug, and then every 4 months thereafter until the study period had ended. Most patients in the tolvaptan group were able to get to the goal dose of 90 milligrams in the morning plus 30 milligrams in the evening, with the majority, meaning 55% of them, staying on this dose during the study period, with the other 45% having to decrease doses as tolerated. Baseline characteristics across the tolvaptan and placebo group were pretty well matched, with about half of participants being male, an average age of 39, a total kidney volume of 1,700 milliliters, and an eGFR of 82, meaning, again, most patients were in CKD stage 2 at the time of randomization. So probably pretty early disease. The primary endpoint of the Temple 3-4 trial was percent change or average yearly percent change in the total kidney volume during the study period. Patients in the tolvaptan group experienced a 2.8% increase in the total kidney volume versus a 5.5% increase in total kidney volume over each year, which was a statistically significant difference. This remained true even in subgroup analyses of males versus females, patient age, less than or greater than 35, whether or not the patients had presence of hypertension, eGFR, and total kidney volume. However, it is important to note that the difference in total kidney volume did appear to be more significant in the first year of treatment compared to the second and third years of treatment. So maybe some more initial effects in that first year, but kind of diminishing returns as years go on. The secondary endpoint that was evaluated in the Tempo 3-4 trial was treatment effect on kidney function, which was evaluated by the average yearly slope decrease in kidney function. And that was measured by the reciprocal of the serum creatinine level in our patients, which appears to be pretty linearly correlated with eGFR. It was found that tolvaptan was associated with less decline in renal function compared to placebo, with a difference of 1.2 milligrams per inverse milliliters, and that was found to be statistically significant. It's important to note that this outcome in particular appeared to favor tolvaptan in males. Patients who were less than 30 or greater than 35, those with hypertension, and those with a total kidney volume of greater than 1,500 milliliters. In terms of adverse drug effects, rates of ADEs were similar in the tolvaptan versus the placebo group at 97.9% versus 97.1% respectively. However, there were more significant serious adverse effects in the tolvaptan group compared to placebo at 15.4% versus 5% respectively. Those serious safety events included elevated LFTs, which occurred, again, more frequently in our patients in the tolvaptan group. When we're looking at these elevations in LFTs, this was usually clinically significant, up to 2.5 times the upper limit of normal, and did usually resolve with the withdrawal of medication. Other side effects that you can see here that were noted by patients included thirst, polyuria, nocturia, dry mouth, fatigue, and dizziness, and these were all more common in the tolvaptan group compared to placebo. Overall, the conclusions from the Tempo 3-4 trial suggested that tolvaptan may slow kidney growth and decline of renal function in the short term, but long-term benefits were still largely unknown. It was also suggested that through this trial, that patients with more significant disease burden may get more benefit from medication administration. These findings ultimately led to the Tempo 4-4 trial, which was an open-label extension of the Tempo 3-4 trial. So they included patients who were in the Tempo 3-4 trial, and those patients did have to enroll within 6 months of completion of the Tempo 3-4 trial. Of note, they also had more stringent requirements for eGFR, so patients, or less stringent, I guess, patients had to have an eGFR of greater than 30 versus 60 in the Tempo 3-4 trial. The intervention group was patients who received tolvaptan initially, so meaning early tolvaptan versus delayed tolvaptan, as patients who did enroll in this trial who had received placebo and the Tempo 3-4 trial were given tolvaptan at the start of Tempo 4-4. Patients were titrated to the same target dose of 90 milligrams in the morning plus 30 milligrams in the evening, and were evaluated at from baseline at the Tempo 3-4 trial initiation to month 24 after enrollment in the Tempo 4-4 trial. So it's an additional 2 years of data for these patients. Similar to the Tempo 3-4 trial, this extension trial did evaluate percent change in total kidney volume, and of note, patients who were treated early did end up actually experiencing less of an increase in total kidney volume compared to those who had that delayed start. However, this was not statistically significant as demonstrated by this p-value of 0.38. Overall, the Tempo 4-4 trial did show similar findings as the Tempo 3-4 trial in terms of the largest effect on total kidney volume being in the first year of treatment, with less impressive effects in subsequent years. The secondary outcome of change from baseline eGFR and also suggested no difference between early and delayed treatment with tolvaptan. So if you kind of think back to how we monitor disease progression, this kind of fits in with we can monitor total kidney volume to maybe be a surrogate endpoint of disease progression, but changes in eGFR are maybe not so acutely visualized. So ultimately, the Tempo 4-4 trial really showed us that there's no sustained difference in total kidney volume, that there is an eGFR benefit of tolvaptan long-term through 2 additional years of follow-up, and that patients in the early versus delayed start of tolvaptan ultimately had similar outcomes, as really the outcome we care about is progression to end-stage renal disease. Lastly, I want to review the REPRISE trial, which essentially sought to just replicate the results of the Tempo 4-4 trial and really further educate us on who would benefit most from treatment with tolvaptan. This was another phase 3 double-blind, placebo-controlled, randomized controlled trial with major differences compared to the Tempo trials, being that this included a population with a worse eGFR, so eGFR of 25 to 65 milliliters per minute per meter squared. They also extended the age range for patients who were included to up to 65 years. Intervention was tolvaptan, and you'll notice this was a little bit more aggressive for dosing, at least in the interim. However, patients were able to decrease their dose if necessary based on tolerability. Oh my God, I don't know what I'm doing, sorry. A total of about 1,300, so 1,370 patients were randomized relatively equally between the 2 groups, so tolvaptan versus placebo. And baseline characteristics, again, were well matched. Patients had a mean age of 47, which you'll note is older than the patients in the Tempo trials by about 10 years. And most commonly were in stage 3A or stage B CKD at the time of randomization. So again, worse renal function than patients in the Tempo trials. Primary endpoint for the REPRISE trial was the change in eGFR from baseline to 1 year, with adjustment for the duration of the trial that the patient completed. As you can see here, patients in the tolvaptan group had less of an eGFR decline at 1 year compared to placebo, and this was considered to be statistically significant. These results were consistent across all subgroups that were analyzed, with age, sex, race, baseline eGFR, chronic kidney disease stage. However, appeared to be more significant in patients who were less than 55 and around stage 3 CKD at time of enrollment. Adverse effects were similar between the tolvaptan and placebo groups and really mirrored what we found in the Tempo trials themselves as well, with an incidence of 85.3% in the tolvaptan group and 82.3% in the placebo group. Patients, again, in the tolvaptan group did experience more significant LFT abnormalities, which was similar to what, again, was found in the Tempo trials. The overall conclusions from the REPRISE trial are that tolvaptan can be effective in patients with later stage AD-PKD, but overall long-term effectiveness is still largely unknown, as this was just a 12-month follow-up study. The study team suggested that tolvaptan may delay progression to end-stage renal disease from 6.2 years to 9 years in patients with AD-PKD based on extrapolation of their data with eGFR. However, I think we have to be really cautious with really believing this extrapolation because we simply don't have the long-term data to suggest that this benefit will actually continue, especially with what we've seen in the Tempo 4-4 trial, being that the effects of tolvaptan seem to decrease over time and are not as good the longer the patients are on the medication. With that evidence, tolvaptan did become the first FDA-approved medication for the treatment of autosomal dominant polycystic kidney disease. Of note, it also has FDA approval for the use of euvolemic or hypervolemic hyponatremia, but I won't touch on that. However, package labeling and the FDA does suggest that patients who are at risk for rapidly progressive disease or have rapidly progressive disease are probably the most likely to benefit from treatment. So this includes patients who have a large total renal cyst mass, given their age as measured by total kidney volume, chronic kidney disease stage 2 or 3, and rapid deterioration of renal function, systemic hypertension, or the presence of albuminuria. Which patients should not receive tolvaptan? Those who have concurrent use of CYP3A4 inhibitors that cannot be modified, patients who, for whatever reason, are unable to respond to or sense thirst. So patients with mental disabilities maybe would not be a great choice to start tolvaptan in if they can't respond to thirst or don't have the mental capacity to understand that. And we'll talk about why shortly. Those who are anuric and those with significant hepatic impairment. Dosing looks very similar to what we saw in the Tempo 3-4 trials. So the dose does need to be titrated up slowly, starting at 45 milligrams plus 15 milligrams on week 1, and then going up to 60 plus 30 in week 2 to a target dose of 90 plus 30 starting on week 3. It's suggested that patients should stay at whatever dose is tolerated to them based on the side effect profile. There are no renal dose adjustments. However, as I had mentioned on the previous slide, tolvaptan is contraindicated in patients with significant hepatic impairment. And if hepatic impairment does occur while the patient is on tolvaptan, there are toxicity dose adjustments or holding parameters for practitioners to follow. So if LFTs rise to greater than 2 times the upper limit of normal, tolvaptan should be discontinued and repeat testing needs to be done 48 to 72 hours after discontinuation. And if the abnormalities or the elevations have resolved, patients can reinitiate treatment. If the LFTs ever rise above 3 times the upper limit of normal, tolvaptan should be permanently discontinued and not reinitiated because there have been some studies or some patients who have progressed to end-stage liver disease and have required not only renal transplant, but also hepatic transplant secondary to hepatotoxicity from tolvaptan. In terms of pharmacokinetics, tolvaptan is not a super exciting drug. Modest bioavailability of about 56%. Pretty well distributed throughout the body, is very largely protein bound, excreted in the feces and urine as unchanged drug. I think the most exciting and most notable thing as a pharmacist to know with tolvaptan in terms of PK is that it is a substrate of CYP3A4 and is extensively metabolized by CYP3A4. So lots of drug interactions for us to look out for. Not really great evidence suggesting how we would dose adjust for this, but probably avoid use with strong CYP3A4 inhibitors or inducers. We talked a little bit about the adverse drug effect profile of tolvaptan just with the clinical trials. Most commonly, we see polyuria, polydipsia, dehydration, hypernatremia, hypovolemia, GI upset, dizziness, fatigue, and then again, that hepatotoxicity. So clinical pros for patients who are on tolvaptan, they need to drink plenty of water to avoid dehydration. And if a patient, for whatever reason, doesn't have access to water, they need to be educated that they should not be taking their tolvaptan doses. And it's okay to do kind of a little drug holiday if for whatever reason you're going to be in the middle of nowhere with no water. Although if you're in the middle of nowhere with no water, you probably also don't have your tolvaptan. So moot point. For the hepatotoxicity, there is actually a REMS program for tolvaptan, so both patients and physicians do need to be enrolled in this REMS program as well as the dispensing pharmacy. So if you haven't caught on, if you don't know much about REMS programs, tolvaptan usually comes from a specialty pharmacy. Because of this risk for severe hepatotoxicity and liver failure, there is some pretty significant monitoring of LFTs that needs to happen, especially around the time of initiation, because the greatest risk for this hepatotoxicity is actually within that first 18 months of therapy. As I had previously mentioned, it's usually reversible upon discontinuation, which is why we like to do some pretty frequent monitoring. So at baseline, week 2, week 3, and then once you get to 18 months, you'll go, or monthly for 18 months. And then once you get down through that 18-month phase, patients can start being monitored every 3 months. All right. So ultimately, bringing us back to our patient case. MK has gone and seen his nephrologist and has demonstrated a rapid decline in renal function over the last year. His total kidney volume is 1,500 milliliters, and he has an eGFR of 35 milliliters per minute per meter squared. Which of the following medications might be a good option for delaying progression of his AD-PKD? Is it A, sirolimus, B, octreotide, C, tolvaptan, or D, all of the above? Yeah, so I'm seeing a lot of C's in the chat. So MK definitely has signs of progressive renal dysfunction based on this history that we've heard. So probably would be someone who might benefit from the use of tolvaptan, and pending insurance coverage and patient agreeability to enroll in that REMS program might be a good medication for him. So overall, in summary, ADPKD is an inherited disorder of the kidneys that does usually result in end-stage renal disease. We often diagnose this via imaging with a limited role for genetic testing. Guidelines for optimal treatment are currently lacking. We do have some conventional treatments recommended, including tight blood pressure control, maintaining adequate hydration, and lifestyle modifications. There are many non-conventional ADPKD renal protective treatments. However, the only one that has been shown to potentially improve outcomes and be FDA approved is tolvaptan. With that, what questions do you have?